Most running is straight plane, but if we're talking about the athletic population after Achilles, we got to make sure that they can cut and change and put different type of forces through the Achilles. It's not just sagittal plane, straight front to back. It's 45, it's 35, it's 27-degree angle push-offs, right?
Hi, everybody. Doug Adams here with Scott Greenberg from the RunDNA podcast. Excited to bring you another episode. I have had many running injuries, most, I think. This is one that I hope I never have, but something that Scott is very near and dear to him, and something that if you listen to some of our other episodes, he said this was his favorite thing to treat. So we're going to talk about post-operative care for Achilles ruptures. And so I hope most people don't experience this, but if you're in the physical therapy, athletic training, chiropractic space, like you're going to deal with these injuries at some point, and it's a really good idea. And I like to take a little perspective on it, even talk a little bit about some of the early phases, but I'd like to really go into even some of the running, because I'm going to interview Scott a little bit more. My bread and butter is post-op ACL. I've done some publishing and continue to do a lot on this, and Scott, this is really his bread and butter. So Scott, default to you how you want to go into it, but maybe we just start talking about like early phase. When somebody comes in, let's just dive right in. What are you doing? What are the key things that you want to achieve in that first week or two of rehab when somebody comes into you?
I think it's important, and probably one of the most important things to discuss. But you also got to understand what type of Achilles repair they have. Did they have a traditional open repair, which again is probably it's still out there, still see it to this day. It's becoming less and less, I think, popular, or less and less the common. You're seeing some of the more mini open or the percutaneous kind of type of procedures being performed, where you don't have to fillet the Achilles open quite as much, and really kind of it's how they tie the knots a lot of times too is really what makes the big difference. In the traditional open repair, you're getting a proximal and distal portion that's pulled together and then literally sutured together. And you get this big bolus and this knot type of repair. A lot of the repairs they're doing are now more knotless repairs, where they actually go in and they actually suture, we'll call it horizontally across the tendon at the proximal and distal end, and then leave the threads kind of hanging off the sides, and actually tie the threads together from the lateral and medial side of the tendon, as opposed to actually going through the heart of the tendon and suturing through, in essence, two pieces of tissue that have exploded, for lack of a better term. Right. So I think it's a cleaner repair. I think you get a lot less scarring, negative scarring, we'll say. It's a lot less of that big bolus, knotty kind of tissue that you've previously seen. And then there's other things that you can kind of bring into that type of repair, which is more of like the traditional, the speed bridge repair, which is like an internal bracing type of procedure, in which you're actually taking the proximal portion of the tendon and lopping it down and anchoring it into the calcaneus. So again, depending on the type of procedure you had done, you can be a little bit more aggressive with certain ones versus other ones, etc. But the most important key to rehab early on with Achilles repairs is, number one, you've got to protect the repair and protect the wound, right? Wound closure, to me, is paramount in this type of procedure, because and that's, again, one of the reasons they started to move away from the total open procedures, because, again, a big, large incision there opens you up for more infections, and also not a whole lot of skin there. So if you don't get good closure initially, you can open yourself up to having to go with the grafting, and it becomes a bigger mess at that point. Infection obviously is something you have to consider. The larger the repair, also the larger the incision, the more likely you are to have any type of infection. And that's again another thing to really be aware of, mindful of, and really try to limit at all costs if you possibly can. So that would be the first part: incision closure, and then protection. Really trying to avoid early on any type of hands-on dorsiflexion type stretching. One of the things I learned at an early stage is never, ever, ever stretch the Achilles into dorsiflexion passively. If at some point somebody's not getting to neutral and they have to actively do it, or active assistively do it where they're in control, that's fine. And actually, if you want to work on dorsiflexion, sometimes some active contractions at a later point into dorsiflexion is fine. But you can actually gauge the amount of force better if you are the patient rather than the practitioner giving that force. So
So
you
Scott, I have
really,
a question about
yeah,
that
yeah.
because so one of the things, similar to ACL world, my understanding of Achilles is a couple key things include early weight bearing, and a lot of the reviews and the literature talks about also mobilization. So that was going to be a point I talked about, to say like I like a hands-on a mobilization of the ankle and the foot is really important, but maybe you can clarify about that with your last point about saying you're not really stretching them into dorsiflexion, but the arthrokinematics, or how the joint is moving, is important as well. And you really want to make sure that early stage you're getting early weight bearing and you're getting some of that early mobilization. But that's not synonymous, or you can specify this more, but my understanding is that's not synonymous with passive range of motion. That's getting kinematics back, right?
Yeah, I would agree with that. So early weight bearing has been shown to, again, I think, accelerate the healing process. Right, you're getting more
Mhm.
blood flow to the area. That doesn't mean that you get them into a normal shoe right off the bat. It means like weight bearing is tolerated in a boot earlier. As
Yeah.
opposed to being non-weight bearing for 6 to 8 weeks. You can get them in a weight bearing boot for 2 weeks out with a heel lift, and then start to wean that heel lift down over the next several weeks, and then get them out of the boot and into a shoe with a heel lift. And they're still using crutches on and off depending on where they are in that spectrum. But early weight bearing is something I believe in. I think the research definitely bears out that you're no more likely to rupture the Achilles by
Mhm.
early weight bearing. Um, so I think that's a positive thing. And then in terms of range of motion, I think range of motion into inversion, eversion, and plantar flexion are obviously fine, especially if you're doing it actively at a say 2 week mark is when I'll start
Yeah.
some of that. The first 2 weeks they're probably in a cast or some type of splint, really making sure the wound closes. And once the wound's closed and any type of sutures are removed and things are kind of looking better, then you can start that active range of motion. And like you said, going after the joint is different than going after the actual tendon and soft tissue. So I
Mhm.
think I'm not opposed to going after the joint, but I typically don't do that in the early stages. I will typically wait a couple of weeks before I go right after that talocrural joint. And I would basically see how the patient is progressing with their own range of motion. It's kind of like one of those things. I liken it to the shoulder, right? So you have these guardrails of after, let's say, a bank card or a slap. There's some range of motion limitations, right? But if the person's getting there easy, you don't. There's no need to stretch them, right? There's no reason. But if somebody is tight, you might want to push that range of motion a little bit earlier, and like this range of motion is going to be like a battle with this particular patient. So you're not afraid to be a little bit more aggressive, as opposed to that shoulder that's just right from the get-go real loosey-goosey. You're going to protect that one a lot more. Same with the ankle, I'd say. If somebody's getting their motion back and they get to neutral dorsiflexion fairly easy actively, I'm not going to worry about stretching them. I usually find that once you get them weight bearing in the shoe, that range of motion comes back fairly quick as body weight just gets pushed down through it.
Yeah, so, I think about, like, ACL and knee patients. You can pretty much always mobilize the patella. With, shoulder, you can always work on scapular stability most of the time. There's always exceptions to this, right?
Sure.
But, you can work on scapular stability and scapular mobility and things like that. So I've limited experience with some of these. I've maybe done between a dozen and a dozen and a half of these post-operative, but I always really like doing my talocrural joint mobilizations early on, because I do think that they like the mobility a bit there, and it is almost more you're getting in that like grade 1 to 2. But I do them in seated like position, where they're sitting off the edge with their knee fully bent to 90 degrees in a pennant position, and I'm kind of mobilizing. I'm doing the hand motion for those people listening on the podcast. Check out
Mhm.
YouTube if you want to see the videos.
Mhm.
But I'm kind of doing some mobilizations there, and I even work like the corners a little bit, and I'll work some of those things. And like I find that that's similar to like working the knee for the patella, that it's going to give them some relief with some of that stuff.
I tend not to do that. I
Yeah.
tend to be a lot more cautious. Again, one of the things, especially in the athletic population, you're going to have to worry about is tissue creep, right?
Mhm.
So you don't want an athlete to lose their we're going to call it rigidity. that ability to load and explode. And oftentimes, if you're too aggressive early on, even though you're going after the joint, especially in the position where you're talking about, where the leg is dangling in a seated position and the ankle is getting, starting in a plantar flex position, moving up to 90, I tend to not want to put any undue stress on that tendon early on, and really tend to just let the healing take over and do what it needs to do during those phases. If you're in a plantar flex position and you want to do some light mobilization of the, some PAs and such, that's fine. But any type of mobilization with movement or any likelihood of lengthening that tendon, I really, really try not to do, because I think the risk reward there doesn't bear out for me. I really want to make, I think, and here's the other thing is a patient isn't going to necessarily have pain if you do it. But what they're going to notice in later stages is that they're not nearly as explosive and is not nearly as strong as they could be if you would have allowed that tissue to really kind of settle in and heal down a little bit better.
Okay, so early on here, anything else that we should really consider, kind of quick takeaways that in the early phase, things you're really, looking to incorporate or things you're really looking to avoid?
So the things, number one, it's wound healing,
Yeah.
it's early weight bearing, it's avoiding overstretching unnecessarily the tendon, and then getting that strength back as quick and as quick as you can, right? Maximizing that strength, because again, the thing that holds athletes out of participation towards the end and really kind of is really the gauge as to when they get back is that strength symmetry, like where they are. Can they do the things they need to do to protect themselves? Can they do the things they need to do to be at the performance level they need to be at? So one thing that I like to implement early on, literally day one post-op, I'll do blood flow restriction on the uninvolved side because there is a little bit of a systemic effect, right? So we know we can get some benefit there. And then literally, as soon as I start the ability to do some light ankle pumping and some light ankle circles, I'll throw the BFR on and do it while they're doing those exercises. Because again, yes, it's not necessarily 20% of their 1 rep max, but for me, if I can create an environment that is closer to that 20 to 30% of their 1 rep max, as opposed to the 70, 80, plus use the BFR to really heighten that response, I'm going to do it. I have nothing to lose in that situation and only things to gain by putting the blood flow restriction on. So I use it early on, and then literally this is the population I find to be probably the best suited for blood flow restriction in the lower body, because again, calf atrophy is one of the biggest limiting factors as to when these people get back. And if we can get them back quicker by getting them stronger quicker, I think we're getting ahead of the 8 ball there.
So when do you initiate like more traditional type strengthening, or what's your progression? Like when do you start the strengthening? What do you do? Do you do full range? Do you do limited range? Obviously, we're not going into dorsiflexion, like those things, but when do you start some of the strength stuff?
So I think a little bit will depend on the physician you're working with, what their comfort level is, right? So I think somewhere between probably around 3 to 4 weeks out, I'll usually start some TheraBand resisted, light TheraBand resisted inversion, eversion, and dorsiflexion to neutral. And even if they go a little bit beyond neutral actively, I don't think that the force that they're generating is going to be problematic. But usually I hold them to neutral into dorsiflexion. And then we usually wait about 2 weeks or so, give or take, to get them into plantar flexion. And then we just progress the resistance for there. Again, whether we're using, I do blood flow restriction with all this. So again, the bands that I'm using are fairly light, but at the same time, we're maximizing the effect of it.
Yeah. What about, we're going to get later to running gait, but what about walking gait? Like when can you start walking with them, and what are some of the considerations that we're looking for? What are you typically seeing people are accommodating, or how are they altering their gait mechanics? Because we talk a lot about running on here, but I think walking gait mechanics is so important early on. I use the 3D motion analysis for post-op anything really early on to be able to see it and identify some of those barriers. So what do you see in this population?
Like I said, it's a progression from, weight bearing is tolerated with weight bearing is tolerated in the boot with crutches, progressing off the crutches, then slowly lowering the height of the heel lift in the boot. When you're ready to get them out of the boot and into a normal shoe, again, I get them back on the crutches. I put the heel lifts back in, and then about every week or so, I lower it down. So somewhere between, 8 weeks or so, give or take, we try to get them into a normal shoe. Again, depending on how each person is individualized there a little bit. But roughly speaking, around 8 weeks or so, we'll get them walking in a normal shoe. The things you tend to see, the limitations are the push-off strength, obviously, and
Mhm.
then the ability to get into, having the affected leg be the trail leg, and almost like not being able to get into that dorsiflexion position quite as much. So they're kind
Right.
of either turned out a little bit, or they rise their heel a little bit quicker than they need to. But again, trying to limit the stretch on the tendon is really important. So I'm okay with that if they're not able to necessarily get into full dorsiflexion at that point. Strength, strength, strength.
Yeah. And this is where it just shows you how important it is to understand biomechanics of
Mhm.
movement there. Because when somebody's walking, we know that, and there's good studies. Actually, I just saw some posts on this recently about how when you go into dorsiflexion, that the most stress on the Achilles tendon isn't at push off.
No.
When they're going into dorsiflexion during stance phase, and they're
Mhm.
seeing that there. And that push off during, like, I don't think a lot of people understand that push off is very limited amount of that actually goes towards forward propulsion. The
Mhm.
majority of that goes towards swing limb advancement and
Correct.
clearance of
Correct.
that. So it's not as much like you want them to get the even step length, but I think what you'll see more commonly in this population is that they might be in a stiffer position during stance phase, and you're almost going to see some altered mechanics on the uninvolved side accommodating for some of those changes.
I think that's true, but I think also I think I agree with that 100%. But what you'll also see is, because they probably haven't been very aggressive yet with their ability to get up and down on their toes, they're
Mhm.
hesitant to do
Yeah.
so during gait. So I think more so than being, and if they're unable to do it, it's due to lack of strength.
Yeah.
Even though it maybe doesn't require nearly as much but the load is definitely different. But the actual strength to push off is going to be affected somewhat, I think, at that stage.
Well, I would think that this is a big reason maybe why early weight bearing is very important, because we also have a lot of sensors and receptors in our foot.
Agree.
And when you are in immobilization, we're going to dampen those receptors. And it might not be even, and what we're saying, and why you want to understand not only just range of motion of gait, but like what is the purpose of push off and what is the purpose? Because we can say, hey, they probably have enough strength to achieve the goal of push off, because it's not real unless they're walking faster. When you walk faster, push off contributes more to forward propulsion. But when you're walking at normal speeds, you don't have as much contribution of forward propulsion. So they probably have enough strength, but they probably don't have enough awareness of what they're doing and their proprioception and their awareness of what they're doing. So when you're doing gait retraining, it might be say, hey, obviously it's going to be an individual thing, like we always say here. And if somebody's having pain, or if somebody is really having a lot more weakness, that might be the part of it. But could really be like, you do need to teach them to push off in this phase, because it's just they don't know that they're not doing it. And we're
Mhm.
looking to improve symmetry, although symmetry is up for debate sometimes with walking, but we're looking, to restore normal walking mechanics as best we can. So I think that's important, and it just shows like the role of biomechanics in any, particularly this one. But we're talking about it specifically related to Achilles. But we should know all the mechanics to say, well, hey, they might be compensating. If somebody with Achilles is coming in and starts talking about their hip and their back hurting, it's probably that their propulsion, they're compensating by increasing the demand on the glutes and the knee extensors in order to get from loading response to toe off and terminal stance. And that's what we're seeing, because they're in a stiffer position. They don't want to go into dorsiflexion. So you have
Yeah,
to
I tend to
understand
see. Yeah, I tend to
biomechanics
see
there.
more of the hip and the back pain related more in this population to the boot wearing than anything
Yeah.
else. So just
Yes.
because, again, that boot creates that asymmetry in the in the lower limb and in through the spine, that I think that creates more problems. So once they get out of that situation, a lot of times they feel a lot better. And
Yeah.
so like I said, this group actually is for me is a really joy to work with, because again, you feel, I feel like I'm always making a difference. I feel like they have very minimal pain. They need us to set some boundaries as to what they can and can't do, and then it's a matter of just gradual progression, and you can see how they improve as time goes on. It's really, really great watching. Just like an ACL watching a quad, right? But
Yeah.
having somebody be able to not go up on both their toes in a seated position, to all of a sudden be able to do it in a standing position, to all of a sudden being able to do it single leg, right? So all of these things slow and steadily kind of return. And then they learn how to hop, and then they learn how to hop on
Yeah.
two legs to one leg, and how high they can get. And we do a lot of testing with our athletes at the right time as to, their counter movement jumps and their drop lands and those type of things to see, what they are versus the other side, or what they were pre and post injury. So all of that's really, really nice to see that progression.
Yeah. So, when we talk about conservative management of Achilles tendinopathy, right, which is very different, I think there's even studies showing that if you have Achilles pain, you're less likely to actually have Achilles rupture a lot of times. Like there's some studies that I've seen floating around about there. But there's a lot of understanding in the rehabilitative world about conservative management, and there's discussion of isometrics and heavy slow resistance, and where does that fall in the post-operative realm of that? And what, because obviously it's all about promoting tendon health. So where do those two start to intersect?
So first of all, when you start talking about conservative treatment for an Achilles repair,
Yeah.
there are people that don't opt for surgery, and there are great
Mm.
studies out there that show that non-operative approach in a lot of ways at 12 months is fairly equal to that of the
Mm.
surgical approach. With regards to, infection rate is obviously higher in the surgical one because you're
Yep.
cutting versus not cutting, right? In terms of rupture and re-rupture rate, in the non-operative group, it's slightly higher, but not really significant. Strength gains are are returned a little bit quicker with the
Yeah.
surgical group, but at a year it kind of balances itself out. So in the right person, the right population, somebody that's not going to need to be explosive anymore, somebody that caught it early and actually was splinted in a plantar flex position within the first 24 to 36 hours to allow that tissue to kind of heal back together a lot better. The outcomes are fairly good non-operatively. So it's something to consider. Now, in the athletic population, you tend not to see that because, again, getting athletes back as quick as we can, having that secondary restraint of that suture, kind of tying it all together, and ways in which we can be a little bit more aggressive early on with early weight bearing, whereas
Mhm.
with a non-operative approach, you're going to be a little bit more conservative early on. So all of that leads to the athletic population skewing more towards a surgical approach. But there are plenty of people that have done very, very well non-operatively. You just got to pick your patient right for that.
All
Now,
right.
with regards to what's
I was
that?
going to say, I don't know if you dodged my question or you
No,
just
no,
went
no,
on
no.
a tangent
So no, no.
there, but yeah.
So with you mentioned conservative, and I think that's
Yes.
we
Yes.
need to talk
Yeah.
about that because not every Achilles repair is going down the
Is
surgical route.
operative. Yeah.
So, somebody that's 40, 45 years old, the weekend warrior tennis player that tears their Achilles may or may not want to have that surgically repaired because, again, their life demands may not need them to be explosive moving forward and such. But with regards to the heavy slow, the eccentrics, the isometrics, I like to throw all of that at my athletes, depending on which one I think they tolerate the best, which one feels the best. Oftentimes, um, isometrics work really good at pain modulation. I
Hmm.
have found, and this holds true whether you're talking about the Achilles or the patellar tendon for that matter. I like to heavy slow resistance versus eccentric. So why would somebody go eccentrics? There's not magic in eccentrics. It's just that patients can tolerate more weight eccentrically.
Hmm.
More weight through the tendon is thought to be better for the actual resiliency of that tendon. However, if somebody's going with heavy, slow, concentric / eccentric, full range of motion in both directions, and you're progressively loading them over time, I think that could be equally as effective. I've had patients tolerate one more than the other in terms of their comfort level, what they enjoy more, what they don't like, what bothers them after the fact more. And it varies. I found that varies from patient to patient. So I like to incorporate exercises of all of that given my sessions. Obviously, I start off oftentimes with like eccentrics, with isometrics, and
Hmm.
maybe I'll try some very light full range concentric, eccentric, and see how they do. And then we may just play with trying a phase of eccentric loading to see how they tolerate that. But in any given session, you may see, and if you look at my exercise logs, I may have components of all three of that given a different exercise for that given patient. So I might do single leg weight bearing calf raises focusing on concentric and eccentric. I might put them on the shuttle in a supine position, going heavy eccentrics, and then I
Yeah.
might get them. I might get them in another situation where maybe they're doing some soleus work where there's a heavy resistance where they can't move it and their knee is bent, and they're trying to almost like you're doing a soleus strength test into like
Yeah.
a dynamometer of something, where you're getting some more isometric work. So I might do all of it, but I think um, patient tolerance for me is what I go for.
Yeah, the thing I like about Achilles exercises, like there are a bunch of variables that you can manipulate, any exercises, right? But I think it's important to understand when you're working on calf and Achilles type loading progressions here, realizing that you can control variables like the time of contraction, right? So an isometric hold, the range of motion, I think is really important because we
Yep.
know that our ability to create plantar flexion force at end range plantar flexion is very limited. So if you're strengthening somebody through full range of motion, your goal is not strength with them, right? Like your goal is taking them through, and maybe it's more muscular endurance type thing. If you're truly training strength, you're going to focus more on some of the mid ranges there where it's strongest because you can lift significantly higher weights with that.
So a couple of
So
things to think
yeah,
about right there. So number one, when I'm doing my Achilles stuff, I'm never going to start them on a step doing a calf raise. I'm always going to start them in a flat ground neutral position. So I'm not putting them into excessive dorsiflexion, right?
yep,
So that's one thing you got to keep in mind, whether you're doing it weight bearing or whether you're doing it on like a leg press machine or so. Make sure that they keep their ankle neutral,
hmm,
and not go into that extreme ranges of dorsiflexion. Again, that's not something I'm comfortable stretching up until probably, I think the studies show that the creep usually ends around the 5 to 6 month mark. So
yeah.
I'm really not pushing that all that much. It usually plateaus around that time, from what I understand. But also, where was I going to go with that? Oh shoot, lost my train of thought. Um,
No worries. While you're saying it, just I think it's important that we just understand the variables that we're manipulating and really make sure that you're considering all of those things. And you could have could look like one exercise, but you could have like three variations on it, and it doesn't have to be really good. And one thing that I really like, and I think maybe when we talk about conservative, this is another spot we'll mention again. There's a video by Karin Silbernagel and her group. If you just look up a exercise or Achilles load per exercise on YouTube and Karin Karin Silbernagel, I'm not going to spell that. Sorry, Karin. But if you just look that up, there's a great video that is showing just how each exercise mimics daily things. So if somebody's not able to walk, there's exercises that are less stress on the Achilles than walking. If somebody's not able to do stairs, there's exercises that are unable to do stairs. So
There's
when
an
you're
article.
exercise,
There's
it's
an
good.
article, Doug, called it was
Yeah.
Baxter 2020, I believe. Baxter 2020 or Baxter 2021, which lists, I believe it's 3 stages of exercise. It's either 3 or 4, but I think it's 3 stages of exercises.
Yeah.
And in each of those stages, it shows the amount of basically the amount of stress on the Achilles tendon, and it basically walks you through all of the different activities from seated calf raises to standing calf raises to lunges, with it being the front leg to the back leg to drop lands to jumping to single leg hop. It basically walks you through the amount of stress in each of those situations, and allows for a great progression.
Yeah. I think those are just good things to have. And like you should just
Mhm.
look those kind of things up
Yeah,
and make sure that you're familiar with it. I'm like getting the link right now so we can put it in the show notes here.
perfect.
Um, because I think that that's really important for you to be able to understand like, hey, what type of exercise you're choosing and how that should impact the body there. And it just goes through a whole progression there. So I'll find that and we'll put
Yep.
that in some show notes there too.
What I was going
Carl
to, I remember what I was
Stelling.
going to say, Doug. I forgot the
Yeah.
point, but like you were talking about strengthening to certain ranges. What I have found also really,
Yeah.
really, like you said, it's the terminal ranges of plantar flexion which tend to be the weakest, and oftentimes
Yeah.
people use momentum to get them to that point during like a calf raise or such. So
Yeah.
if I can start them with a slightly elevated heel and have them
Mhm.
raise their calf from a static elevated heel position to that end range, I find
Yeah.
that really kind of weeds out, it separates the men from the boys, so to speak, right? So it really makes it more difficult to do that.
Yeah. Yeah. Um, yeah, and that's great. And then, but if you were trying to truly improve strength, you would want to start more in like the mid ranges and make sure that you're focused on some of that too.
Hmm.
Yeah, and one of the things just for exercises, I think it's also really important. I had, I work with a lot of athletes and a lot of the professionals that come and see me. I help them remotely. A lot of times they call me up. I got a call last night from one of my athletes, like, "Hey, this has hurt me or that's hurt me." And it's also important that you give good cues to people to understand where they should be feeling it and make
Hmm.
sure that they understand. Like I've seen a lot of people that do calf raises, especially after Achilles issues, where we need a little bit of inversion, right? But when somebody's going excessively inversion and they've lost complete weight bearing through the first ray at all,
Hmm.
there we'll see that. So I tend to give cues about when I'm doing exercises where they should feel it, right? And for the majority of the exercise, saying we want make sure that you're still feeling some weight bearing underneath of that knuckle joint under your big toe, and that helps them to really understand where they should be feeling it. And then all of a sudden you'll see that like the range goes down and they feel it in a different place. It's like, yes, that's what I want. So work on your cueing and make sure you're giving appropriate guidance on what they should be feeling while they're doing the exercises.
Hmm.
Yeah.
Yeah, agree.
Um, all right, so let's jump forward a little bit here because we've already talked about a lot of good stuff. But let's jump forward to the return to running because a lot of people are interested in running or runners with this here. So, tell me about some considerations. Some thoughts of even maybe some points to hit on treadmill versus over ground. Are they in a heel lift to start? Or do you recommend a high heel to toe drop there for some of the things? Like what are some of your considerations or tools, body weight support? Like what are some of the things that you think about when you're getting somebody back to running?
Um, Great question. So I think a lot of it comes back to, can they tolerate the ability to load and explode? Do a progression of, can you hop in place on two legs? What
Mm-hmm.
does it look like on one leg? Can you switch between one and the other? Where we are in the whole spectrum of time too,
Yeah.
right? So we want to make sure we're conscious about that. At our facilities, we're lucky to have, boost treadmills or Alter G treadmills to really assist me and us with those type of progressions. So that's where I'm going first with regards to my return to run program. I will get them in the gravity assisted kind of situation where they're running, at a relatively slow speed for, 5 minutes, let's say at 70%
Mhm.
of their body weight. I think um, I tend to keep my treadmill fairly level.
Mhm.
Again, if you got to be if you bring them up into an incline, can their ankle tolerate that amount of dorsiflexion? Can you assist them a little bit by going downhill because the stress on the tendons a little bit less? But again, depending on what their gait mechanics look like, um, I think you have to look at if somebody's a toe runner or a rear foot or a forefoot striker. I think obviously forefoot strikers are going to put more stress through the Achilles tendon than a rear
Mhm.
foot striker. But that being said, somebody that is with prolonged pronation may actually, and a lot of rear foot eversion may kind of create a different kind of stress on that Achilles tendon. That's right, more of a twisting kind of motion through the Achilles tendon. So I think all of that needs to be kind of looked at, and they can't be. I don't think we can make a blanket statement for everyone. I think it's got to be more individualized with your approach as to how you want to minimize the stresses. Again, I think a heel lift can be helpful in certain cases. Like you talked about, a higher heel drop shoe, or even maybe an orthotic with a little bit of a lift built in, or just a lift. All of those can be appropriate.
Yeah.
Um, but I tend not to worry too much about that unless something's really kind of glaring. I try not to make too many early on in this process. I try not to make too many recommendations to change their gait. And I do the same thing with my ACLs. For the first couple of times, I just want them to run what's comfortable for them, get used to the act of running, as opposed to throwing so many cues at them initially, right? So just get used to, and I won't do a video analysis of them for their first couple of times on any type of return to run program here, because again, for me, there's more important things that I'm worried about than truly what their form looks like in that situation. I want to make sure that they're confident and they're not favoring it, so to speak. Whether they're a rear foot striker or a forefoot striker, and maybe they could be more efficient. That can come later on. I just want to make sure that they are pain free, not favoring it or limping, and try to minimize the stress on that tissue as best I can.
Yeah, and Scott and I have, in teaching courses, we've gone back and forth on this. I think we had almost an hour discussion about this one time, because I am doing gait analysis much earlier on, and I'm focusing on cues. And I think we agree, in the most part, about keeping it simple and
Mm-hmm.
just focusing on. I think that's where we really agree on it. About it doesn't have to be perfect form. It is by no means are we trying to do the same level of gait retraining that we would maybe do for
Right.
somebody that's non-operative or something. Like, there's different goals for the gait analysis, but I'm much more likely to put somebody a gait analysis the first time that they run and start to give them proprioception. Because in my mind, I think what a lot of these injuries lack is proprioception of what they're doing and giving them awareness. And now it's different because I have the ability to give a live 3D view of what their knee is doing post-op ACL right away, and they can see the difference. And it's not that I'm cueing them a ton. I'm just like, hey, see the red and the blue, like the red is you're involved, the blue is you're uninvolved. Like, try to improve these just a little. Like, how does that feel if you do that? And I almost use it more as a diagnostic tool to say, oh, hey, they're still not very confident in going into a weight-bearing knee flexion, and I should get them back and check how they do on a lateral step down or a loading progression, like Scott was talking about earlier. So we're different but similar in, like, don't, like, I think what we would both agree on is don't overcomplicate it and just let them kind of adjust. But what you can, I think my main goals are more around proprioception and getting them to be aware of what they're doing, is really my prime goal with this. And then in this specific instance, also understanding how, yes, if they are having pain or an issue with this, you should understand that a treadmill does put more stress on the posterior chain, and that it is going to make them more likely to land in a forefoot position. And that's why we should understand the differences of treadmill versus overground running, and be aware of those things. But the goal early on is just making sure that they're feeling competent and confident in it there. And then you don't have to do everything at once. I think Scott and I are in agreement with that. I just like to give them a little bit more proprioceptive feedback as much as I can, but I have that at my disposal, which is different.
Yeah, I very rare. And so if an Achilles repair that I'm seeing, jumps on the treadmill and right off the bat, they're running on their toes.
Yeah.
Which is very rare to have happen, right? They're not
Mhm.
going to. That's not the way they're going. They're going to be very, very.
I gotta like it.
They're going
Yeah.
to go the other way. But if for this case they did, that may be somebody that I jump in a lot quicker and say, hey, back off the forefoot quite as much. Maybe try to land a little bit more natural through your foot and those type of things. But
Yeah.
it usually doesn't skew that way.
Yeah. It's normally like relax the foot,
Mhm.
try to like give them some feedback when they look tense and be like, hey, you're really upright, or you're really leaning forward, or like some of those things. And that's where like the gait category sometimes come in, because we know overstriding puts a lot of braking forces on it too, right? So just teaching them some basic cues and some proprioception and getting them in a wall drill or teaching them some marching drills, just like basic general stuff, is really good. But you're not going to hammer it and try to make them perfect with the form early on. But like we've mentioned, like small gains make a big difference with a lot of this early on. So, all right, last thing I'm going to talk about here just quickly, because I mean we could do a whole course on this, right? This could be a weekend long course, but we're trying to give some quick tips here. Jumping,
Mhm.
right? Like when we talk about running, we have in our level 2 course, we have our loading levels progression, and we just talk about how essential it is that we are developing that springiness back. We measure with the 3D, we're looking at stiffness, and we're looking at some of those variables, and I do see a lot of stiffness changes with this population as well. But like what's your thoughts on jumping, of timing? Like, is that before running? Because we talked a little bit about that, about doing that before running. What do we want to get them up to? Where does jumping fall into it for your patients?
I use it early and often, and I
Yeah.
do it. When we start talking running, I think we need to really talk about speed. So running is different than sprinting, and the forces and the or amount of work that the posterior calf complex slash Achilles
Yeah.
needs to do is definitely greater in the faster speeds. Um, but yes, I do. I like to make sure that they can handle load as well as absorb force and return the force back adequately before I get them to make that progression to running or jogging even. So yeah, um, it's just like anything else. It's part of the progression, right? It's like
Yeah.
you got to build up strength. You've got to build, and that's to me that's the most important thing. I think if you can get a good, adequate strength base, everything else kind of falls very nicely into place.
Hmm.
Their ability to load and explode is better. Their overall tolerance for activities is better. Um, yeah, so if you can get them stronger, and the explosiveness and the elasticity components will likely follow.
And this is where I do really like the loading levels assessment because it does really go through some of those basics with it there, the ability to load throughout there. I think it is something that really it's more of a prescriptive type thing of like what type of exercises should you start this person with? Like I love a depth squat. And I think that that's something that you can start people early on because you're not really getting that true plyometric where you're leaving the ground and getting a high rate of force, but you're just teaching rate of force production and you're teaching how to be aware of your posture when you're doing those things. And I think having some guidelines of not just saying, oh hey, you're 10 weeks now so we should start doing these exercises, but actually looking and understanding, okay, you can do a lateral step down, great, that looked good. All right, now we're going to have you jump over a hurdle. Ooh, that didn't look good. Okay, we're still in bilateral activities here and we need to get you confident with some of these things and before we progress on to anything unilaterally there. And having some way to just be able to say, hey, this is about the level of exercise that you should be doing now. I think that gives the patient confidence. I think it gives you confidence. And obviously you have to match it up with surgical healing timeframes. But I think having a guide like that does make a big difference.
Hmm. Absolutely. And then again, running most running is straight plane, but with if we're talking about the athletic population after Achilles, we got to make sure that they can cut and change and put different type of forces through the Achilles. It's not just sagittal plane, straight front to back. It's 45, it's 35, it's 27-degree angle push offs, right? So I
Yeah.
think all of that is part and parcel to train as well, and how they tolerate landing with a perturbation, you know. My gymnasts are good examples of that. They never, when they're tumbling, they never always land perfectly. When you're on a beam, it's a hard surface. So you got to make sure that when you're doing those type of things, your tissue can handle it and you can be explosive in different planes of movement.
Yeah.
So that's just something to consider. I know it's not necessarily for our running population, which is more usually straight plane type stuff. It's part of the equation as well.
Yeah, but running, we might run in a straight plane, but all the other planes are pulling on us. So we have
That's true.
to avoid some of those motions, right? So even though running is an emotion, you're avoiding falling over to the side and you're avoiding twisting inward. So training all of those for runners, for any athlete, almost all sports involve running. So I think that
Uh-huh.
that's an important concept too.
Agree.
So yeah, well, Scott, thank you for sharing here. I think it's good just to hear from somebody that's seeing so many of these because I don't think the typical person, unless you're working directly with a physician that does a lot of these repairs, the typical rehabilitation specialist is not going to have this amount of experience with it. And it's just always good to learn, kind of accelerate your expertise a little bit and learn from things from somebody that's seen it. So
And
appreciate
full,
you.
you're welcome. And full disclosure, you're not going to see a lot of these Achilles repairs in your distance running population. You're not. You're
Yeah.
going to see it more in your sprinters and hurdlers. Like I said, I was seeing, two track and field athletes with this problem recently, and it's not something that you see with your recreational jogger or even your competitive 5K runner, it's going to be more on the explosive 100, 200s, 400s, maybe even 800 type of runners that you're going to see these with. You're going to see it in your triple jumpers. You're going to see it in your gymnasts. You're going to see it in your high jumpers. You're going to see it in your basketball players. You're going to see it in your volleyball players. You're going to see it in your soccer players. Those are the type of people primarily you're going to see it with. Your football players, obviously Aaron Rodgers. But again, it is something that you will see if you work with runners. It's just the force that usually kind of dictates this a lot of times. Not all the time, but a lot of times.
If your distance runners did this, it's probably because they were like on a rec softball or volleyball team or something for work, and
maybe a trail runner. To be honest with you, you can see it in a trail runner who steps funny on a route, or steps off a curb, misses a curb. A distance runner that maybe takes a funny step. That's where you're going to see it. That's where you're going to see it.
Yeah. So hopefully you'll see it, but like I said at the beginning, hopefully you'll never experience it. Even though it sounds like not a scary rehab, it's still something you don't want to go through. So thanks everybody for listening. I hope you have happy and healthy running, and make sure you subscribe and check out the RunDNA newsletter. Subscribe to us on YouTube or wherever you get your podcasts. And thanks for listening today.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. RunDNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The RunDNA podcast is produced by Ace Running LLC. The RunDNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at RunDNA.com.